So we're going to do an abbreviated show today, but on a topic that is so important, especially now with COVID-19 still omnipresent across the country. In many parts of the nation, it is spreading, and we are seeing hospitals that are getting ready to maybe go out of business or change their business models over to some bigger company. We've got smaller primary care physicians who are thinking about abandoning their practices because it is just too expensive with all the regulations that they've been faced with. And now with COVID-19 and the shutdowns where they were basically told you can't have your patients come in for most situations. I mean, so many issues that have just been plaguing primary care physicians across the country. And today I want to delve into that exact issue with Dr. Lee Gross, MD. He is president of Docs for Patient Care Foundation and the owner of Epiphany Health. And he joins us now to dive into several different related topics here, particularly about putting patients back in the center of providing medical care. Dr. Gross, welcome to Jimmy at the Crossroads. It's such a pleasure to have you here.
Thank you so much, Jimmy. I really appreciate having the opportunity to talk with you.
So before we jump into patient care and the model that you are advocating for, you are in Florida. You are a physician in Florida, and I want to know what the environment really is like on the ground there for you guys, especially in terms of the spread, but also the hospitalizations and the death count, because those are, I think, what really matter more than the spread. A lot of people can get the virus, but if the communities are handling it well, that's an important thing that people should know about. So what are you seeing on the ground in Florida right now, Doctor?
Yeah, so as you mentioned, Florida is the world's epicenter now of the COVID-19 crisis. We talk about Italy, we talk about Spain. It's Florida. This is where it's at. And you mentioned we actually have a healthcare crisis right now where it's so bad that we're actually putting our physicians out of business with the policies that we put in place. We are at a point right now where we've canceled elective surgeries, canceled elective procedures to preserve the capacity of the hospitals. And what's happening is the hospitals are largely sitting empty as a result of it. So we're furloughing nurses, we're furloughing staff, we're cutting physician and staff pay because the hospitals are largely sitting empty as a result of the decisions that have made. But we are definitely seeing the numbers in the hospitalizations starting to rise, but nowhere near at the pace of which the number of cases are rising. When COVID-19 first came here to Florida, we were seeing an admission rate into the hospital of about 30% of all cases that were diagnosed. That number's down to about 3% now. And so that is a very manageable figure at 3%. What's not manageable is 3% of 15,000 new cases per day, because these patients stay in the hospital for a while. So we do have to slow the spread, but this is concentrated really in about 6 different counties and 6 different population hubs around Florida. So your main areas where the populations congregate, and then in the other 61 counties in the state of Florida, there really is not a whole lot of disease present, and that's just something that's not really talked about. It's mostly in the nursing homes, it's mostly in the prison population, but we're just not seeing in the general rural communities massive crowding and hospitalization.
Define for a moment, please, what elective means, because a lot of people, when they hear elective surgeries, unless they had an elective surgery canceled on them, they might think of something that's sort of frivolous, that isn't necessary, or isn't something that is important to somebody's health and well-being. Might be just, plastic surgery, for example, that isn't a necessary thing. You might think, oh, that's elective, but that's not the case, is it?
It's anything that's non-life threatening. So elective can be a bypass surgery. If you're not dying of a heart attack right now, then elective surgery can be your gallbladder. It can be removing cancer. Cancer is not necessarily an emergently life-threatening condition, but as you're delaying these services, as people are avoiding the physician, we have a point right now where people are afraid to go to the doctor. And that's the morbidity and mortality associated with people being afraid to go to their doctor is going to be one of the major fallouts of this entire COVID conversation, which is actually one of the important reasons I'm glad we're able to talk about the practice model, because it's something that we have actually been able to audible very quickly and be able to provide care for our patients where other practices were not quite so fortunate. You had alluded to, 50% of primary care doctors right now in a fee-for-service world are near bankruptcy. They're near insolvency. And we're going to see more consolidation in the medical practices. We're going to see more uptake by hospitals buying out these vulnerable practices. And you're also going to see this hit particularly hard in the rural communities as these rural hospitals that were already bordering on insolvency are going to go broke. And that's just not something that we can sustain.
Just one final question, and then we'll jump right into the model with you, Dr. Lee Gross. In terms of ICUs and manageability, I mean, ICU capacity is broader now than it was when the COVID-19 crisis began. So in terms of the ability to manage this, first of all, I think it's pretty remarkable that we've gone from 30% of all cases to only 3% in Florida as far as those who actually need hospitalization. That I think there's a lot there in and of itself. But in terms of that larger 3% number, when you actually say 3% of 15,000 cases a day and what have you, certainly that is a very big issue for hospitals to be grappling with. So in terms of managing it, though, especially with the enhanced ICU capacity, how do you view that as being done right now? How are they handling it in terms of managing the situation in the hospitals?
Yeah, so in the first 5 months of this pandemic, the hospitals have worked on surge capacity. So we were expecting this. Nobody ever said in the COVID response that we have to flatten the curve because we're going to cure COVID by doing that. What we said is we're just going to extend out the number of time it takes for the same number of people to get infected. But the numbers under the curve is not going to change. It's just going to slow. Having said that, we have a wildfire right now in Florida, and we want a slow burn. We want a controlled burn. And so we do have to make smart decisions as a society as to how we're going to get that under control so we don't overburden any particular health system. But when you see that the intensive care units are near full, that is just a licensed bed capacity, but that is not a hospital's ability to take care of patients. They have developed overflow plans, they've developed staffing capacity plans and surge plans to take care of these people. My concern really continues to not be the intensive care unit beds, but the ability to staff those beds. And that's also, why it's very important for the federal government to have an idea of what's going on. I'm sure you've heard the kerfuffle over bypassing the CDC so that HHS can start collecting information directly. That was the ability for the federal government to audible, to be able to allocate medications appropriately, to allocate resources appropriately. And unless you have real-time data as to what's happening in those hospitals, you can't get out in front of this. So that was all part of that whole process.
So, Dr. Lee Gross, let's talk for a moment about the current model, how it's set up, and particularly how COVID-19 fits into that.
So a standard practice is an insurance-based practice, which basically bills on requiring a patient to have a face-to-face presence with a physician in the office. So the way that works in the standard times is every single phone call, every single email must convert into an in-person office visit in order for the doctor to bill the insurance. And typically that office visit's about 5 minutes long, and of those 5 minutes, 4 of them are with the doctor clicking boxes in the computer so they can bill the insurance and get paid properly. And, Lord forbid if you actually have 2 problems, then you need to get in line and come back again. But the Medicare and insurance companies generally did not value technology visits. They did not value a communication like you and I are having, a video chat. That is not something, telemedicine, that's not something that's billable under typical insurance. So what happened when we hit COVID, what we have is what's called a direct primary care practice. We are an insurance-free practice, and the name of our practice, Epiphany Health. The epiphany, in fact, was, why are we insuring primary care? Why are we inserting an insurance company into the most basic aspect of healthcare delivery? And it's a very impersonal product, this insurance product, and yet we're surprised that it's inefficient, ineffective, and impersonal. You don't insure your car, you don't insure gasoline for your car, you don't insure lawn maintenance in your house, yet we're insuring every single aspect, every sniffle, every cough. So what we did was we created more of a Netflix approach to primary care. We charge a flat monthly fee to our patients for unlimited services in our office. So for us, that's $65 for an adult, $25 for one child, and $10 a month for each additional child. And after that, we don't charge anything for services we do in our office. Office visits, technology visits, email visits, skin cancer surgeries, joint injections, EKGs, any in-office testing is all included at a flat monthly fee. So we are charging for, why would I charge you $50 for an EKG when it costs me 3 cents to do it? We've eliminated barriers and obstacles to care, and what effectively happened in this pandemic is it's really stressed the weaknesses of the fee-for-service model in primary care. Because when you started cutting off primary care doctors from seeing their patients in person, you've suddenly cut off their revenue. They have no way of billing. And if it takes Medicare or Blue Cross 6 weeks to change their payment policies, that's 6 weeks of no patient care, no revenue, and these practices go broke. We didn't have to do that. We immediately switched to parking lot visits, technology visits, drive-up nasal swabs, you name it, whatever we had to do, wherever we had to do it.
And that's because
we never had to lay anybody off.
Because you're interfacing directly with the patient and not working through all of these systems necessarily.
We did not need to ask for permission to take care of our patients, and we didn't need to ask permission and wait for a federal mandate. We didn't need to ask for a board meeting from an insurance company to give permission for us to do the right thing for our patients to take care. It happened on day number one. And because we had the steady revenue stream of the memberships, we didn't lose the revenue. We were concerned that a lot of patients were going to drop their memberships when they lost their jobs, but it turns out that never happened. Because I guess it turns out that in a pandemic, the last thing you want to do is drop your relationship with your doctor.
Yeah, it's funny how that is. When you have a pandemic and a virus is spreading, you actually want to keep your primary care doctor handy so that you can communicate. So in terms of this model, I mean, this is not a widespread thing, which you're doing at Epiphany Health. I mean, obviously you have an organization that you're president of, Docs for Patient Care Foundation, that is all about spreading this model of patient care. What do you think needs to be done in order to encourage more physicians to use this sort of model? I mean, are there legal impediments, regulatory impediments, or is it just sort of an awareness thing? I mean, I know that you invested $100,000 in your firm in order to make this thing happen, get this structure in place. Is it a very costly thing? What are some of the things that are preventing other doctors from saying, hey, I'm going to go try out this model because it might just be better for my patients and for me?
So this pandemic, again, was very eye-opening. And we have a unique situation where you have 32 million people in the country that are unemployed. Many times their insurance is tied to their employment. So you now have people that are seeking access to affordable care. You have 50% of doctors in the country that are nearing unemployment. And so that's a perfect match to connect the doctors and patients directly to one another to provide that necessary care. But I can tell you that up until now, there have been several impediments to the rapid uptake or the wider spread uptake of this model. Number one is the state laws, and if a doctor and a patient contract directly to one another for unlimited care, some state insurance commissioners may look at that and say that is an insurance product you're selling, and you should be licensed as an insurance company. Fortunately, collectively, we've now passed legislation in 28 states that say that if a doctor and patient contract for a fixed monthly fee for defined services, that the doctor does not become an insurance company. So that's one of the big ones. So we now have, again, reached that tipping point of more than half the states in the country passing this legislation. We've been at this for over a decade, by the way. The other issue is federal tax policy. The Internal Revenue Service looked at this relationship and said, I'm not really sure a membership qualifies as a healthcare expense. Therefore, this is probably not tax deductible. You probably can't use a flexible spending account with it or a health reimbursement arrangement. Fortunately, again, we've been at this for a long time. Fortunately, we had a very willing ear at the White House in this administration. They really like the access that this provides. And on June of last year, the president signed an executive order that says that direct primary care is an eligible expense for the Internal Revenue Service, and had asked the Secretary of the Treasury to declare that as such.
Well, I just want to say, I think that to me is just like allowing the obvious. Really,
Right.
I don't understand why it would be restricted, except there were a lot of restrictions, especially in terms of how Obamacare regulations were put into effect, particularly under the Obama administration, that inhibited a lot of these types of things through regulation, not just directly from the statute.
Right. But you also have to keep in mind that Obamacare, its teeth are in the tax code.
Mm-hmm.
I mean, that's the enforcement arm.
Right.
The Treasury is the enforcement arm of Obamacare. There are many people still within the Treasury Department, within the Internal Revenue Service. I appreciate all their efforts, but they wrote the rules.
Mm-hmm.
And
that's
they
what I mean.
They sort of see this as an end around to bypass the Affordable Care Act. But frankly, we're here to prop it up. And I mean, we're making it work. We're picking up all the people that are falling through the cracks. I have a small practice in Southwest Florida, and I have patients coming to me from all over the country. we're seeing patients coming to us from outside of the state. We're seeing patients coming to us from outside of the country for inbound medical tourism because we have built a robust network of people around us that work in complete price transparency. They work in cash transactions. I'm right now sitting in front of a hospital that has the only transparent cash prices for inpatient surgery in the country that we've arranged.
Dr. Lee Gross is our guest. Again, he's owner of Epiphany Health and president of Docs for Patient Care Foundation. And one thing that you alluded to before, you mentioned telemedicine, and you're also talking about patients from across the country that are going to Epiphany Health, to you guys, your office, to be able to get care. Telehealth, I mean, that's one thing that I have been talking about for a while, including I think we've done a couple of mentions on this program, but also going back over years on the radio and in other work that I've done. I think we really need to be emphasizing that more, especially because there's a lot of stuff. There are a lot of things that you as a physician can do remotely. There's some things you cannot do, but there are a lot of things that you can do remotely, and there are a lot of regulatory inhibitors that get in the way of first of all, of a physician being able to practice in a state that is different from the patient, but also in terms of telemedicine. So if you could speak to that, especially in the context of its importance in this patient-centric model that you're operating under and advocating for the expansion of, Dr. Gross.
Yeah, so easing up the burden of the practice to how they bill insurance and how it's paid for by the federal government was an important step, and that's one of the first things that the administration and what CMS did in this pandemic is they said we're going to go ahead and pay for these telemedicine visits. Well, guess what happened? We went from 17,000 telemedicine visits a week to 1.7 million telemedicine visits. That just showed you that it was just the regulatory change that opened up that floodgate for thousands of % increase in utilization. The beauty of what we have with our model where we build telemedicine into it as an option is it's just another tool in my toolkit that I can use to treat you. So if I only have telemedicine, then I sometimes may reach beyond my comfort zone and maybe do some things through technology that perhaps need to be done in person. But I have the ability to audible and just flip it and say, hey, come on into the office. And we can just handle that. I can have people text me pictures of things. And what I can do in 3 minutes through a technology visit might have taken somebody a half a day in the past. They'd have to take a half a day off of work.
Wow.
They have to sit into my office. They have to sit with a bunch of sick people in our waiting room in the lobby. And there's no reason for that.
No, absolutely not. And one of the things that this pandemic just underscored, if you don't want people to go into the doctors, at least enable them to interface with their doctor, to get the kind of medical care even remotely.
Right. The other thing that our practice model does is we bring in wholesale pharmacy into it. So we do wholesale dispensing of medications directly to the patient. And if you look at what the federal government did in putting out their accountable care organizations, it took them 7 years to save even the first dollar in those accountable care organizations that are part of Obamacare. Well, you know what? In the first year in implementing this in one hospital, we saved the hospital $1.2 million. It was a 54% reduction in their healthcare costs in 1 year. Now, when you factor in the cost of the prescription drug savings, in most cases, that actually pays for the patient's membership, the savings that they can achieve from that.
We're talking here about the direct primary care model of approach. Now, I want to contrast this for a moment in our remaining minutes with you, Dr. Gross, with an idea that has been put forward from an alternative perspective, rather than saying, hey, let's maybe get rid of legal impediments, regulatory barriers, legal, law barriers that need to be changed and what have you. Get rid of those barriers and unleash this more direct patient-centric model. I think more of a free market in healthcare, especially when you talk about transparency and so forth. You have the other side that says, no, this means we need a lot more government. You shouldn't have private physicians like Dr. Lee Gross providing medical care to people for profit. They should instead all be subsumed under a Medicare for all type of program, basically provide a socialized medicine system under which everybody must live. That's the alternative model that is widely being discussed now. What do you make of that one?
Yeah, the same people that are supporting that exact approach with a one-size-fits-all government approach are also criticizing the government's response to COVID. If you don't think we can handle one virus, how do you think they can handle the entire healthcare system? This is just one itty bitty, problem. You need the ability to have multiple options, and I think this pandemic has made that absolute crystal clear. And keep in mind that there are a lot of people that disagree with the policies of this president and his administration, but that president and this administration would be managing the single-payer healthcare system. Do you really want people that may not share your ideological beliefs making your personal healthcare choices? It just doesn't make sense. The future in healthcare is individual freedoms, individual responsibility, and we need to make all of the most basic aspect of healthcare affordable and transparent for everybody.
Are we closer as a country, Dr. Gross, to having this patient-centric direct primary care model adopted more widely, or is this a rough road ahead, even with the lessons of COVID-19?
It's a rough road ahead because the politicians are practicing medicine, and we sort of joke around when you combine medicine and politics. Well, the answer is politics, and we need affordable wraparound insurance policy for the major medicals, for the what ifs. That's something that's happening. There was a big ruling in the Supreme Court this week to support some of the major insurance plans to offer these low cost, high deductible plans that really are just for the what if I get cancer, what if I have a heart attack. That was a key piece that was outlawed under Obamacare. That's now been brought back. Some people refer to that as junk insurance. And those are the short-term limited duration insurance plans. They're sort of categorized as mini medical plans. But frankly, it's exactly what we asked the administration for. Because we said, look, we're covering the chronic conditions in our office. We're treating the diabetes. We're treating the high blood pressure. So what we need you to do is just have the insurance be in the background, just like your homeowner's plan, to say, what if the house catches on fire? We need a plan for that. Well, they've given us that plan.
So in other words, you would have a system here where insurance is like true, genuine insurance, particularly catastrophic, but genuine insurance is available for these serious situations. But for the everyday issues, you could subscribe to a membership program with your local primary care physician and have that one-to-one arrangement for day to day. Please go ahead.
Yep. And it's cheaper than a cell phone.
Wow. See, here's the thing. I have always been an advocate for the idea that too much government gets in the way of the ability for patient care, but also jacks up prices. It causes much higher costs for people to access the care that they need, which results as well as higher insurance costs and what have you. I think this is exactly the kind of approach that we need to be looking towards across the country and thinking big by looking at a smaller role for government in these ways where you empower physicians like yourself, Dr. Gross, to create these practices where you provide direct primary care, do a one-to-one arrangement with the patients, have a membership program, and then have like what insurance was supposed to be, catastrophic. And I had not seen that Supreme Court. I missed that Supreme Court ruling. I'm very encouraged by that.
Yeah, that was a big win for us. So if you want to learn more, we have a nonprofit foundation where we go around the country, put on courses, and teach physicians at no charge how to convert their practices. We've had over 1,000 physicians across the country come through our training program. It took Starbucks 17 years to get to 17 stores, and we've grown from a handful of practices to well over 1,000 practices in 10 years. And so for those that say that's not scalable, it is scaling at a magnificent rate. And so if you want to learn about the foundation, you can go to www.d4pcfoundation.org. That's Docs for Patient Care Foundation.
D4pc.org.
D4PC Foundation.
I apologize. Thank you. Yes. D4CP Foundation.org. This is innovative, and this is the kind of thing that you get when you don't have a top-down, government knows best sort of attitude. Dr. Lee Gross, I really enjoyed the conversation. Very insightful, and keep up the good work, and I'm sure we'll talk again.
Thank you very much. Appreciate the opportunity.
Thanks for coming on. Again, Dr. Lee Gross joining us. He's president of Docs for Patient Care Foundation and owner of Epiphany Health. And I have to tell you that this is the kind of free market innovation that you can only get from the free market, not from the government. He saw an opportunity. He took it. And it's growing and expanding, and this kind of model seems like exactly the one that we need. Thanks for watching this clip of Jimmy at the Crossroads. Don't miss more engaging, intelligent talk. Subscribe today to the Jimmy at the Crossroads YouTube channel. You do not want to miss our live show. Thanks for your support.
I got Jimmy at the crossroads, making sense out of no sense. Yeah.